All right, greetings everyone. I hope you're doing well and keeping safe. I know it has been quite something globally with this COVID-19, but just to assure you that we hope things will be in order very soon. Stay home, keep safe. So today we want to look at somatoform and dissociative disorders, and I'm just picking this class from our past class of child psychopathology. We're looking at different types of disorders, and we're going to look, we've been looking at various types already, and today our focus is on somatoform and dissociative disorders. As we look at this, I'm hoping that by the end of this class, all of us will be able to understand or define, explain what somatoform disorders are, dissociative disorders are, and they're coming in various subtypes. We'll be seeing each of them, and we hope that you'll be able to have this knowledge, especially for you counseling psychologists who are going to the field, to be able to use this kind of knowledge in impacting your clients when they come or present with these disorders. So when we talk about somatoform disorders, basically these are disorders in which individuals or clients present with physical complaints, even though there is no medical explanation about that physical complaint. So they will have gone to various hospitals, or they would have seen various medics for specific treatments, but there is no medical condition that then can explain the condition that they are suffering. And especially for us coming from this cultural background of the African, there could also be various explanations for that. But I think as professionals and people who are going to help our clients, you understand that the client is presenting with a real pain. They're presenting with a real physical complaint, or a pain in the back, or a certain headache that they cannot explain. But behind that, there's no medical explanation. So you can be sure it's not very easy to convince someone that no, there is no medical condition, you're not sick. It's very, very difficult. But I know that with help and using our knowledge that we've gained in the various in this program and your own experience, you're going to help the clients see what exactly this means. On the other hand, dissociative disorders usually are these disorders that individuals feel detached from themselves and the surrounding. And we're going to see various types of these disorders as we learn. And the key word is this word soma. Soma means basically body. And this is where someone is preoccupied by their appearance, or they're preoccupied about how they look like, without a medical explanation about how they're feeling. So for this specific class, we look at various types of somatoform disorders. We're going to look at hypochondriasis. We'll also look at somatization. We'll look at conversion disorder. We'll look at pain disorder, as well as body dysmorphic disorders. So I hope this is going to give you some knowledge, so that when you see clients of these kind of disorders, you can know how to be able to treat and help them. Remember, always we insist that currently our reference of diagnosis is the DSM-5. Always have it as you make this diagnosis. Again, just remind us that before you make any treatments, you need to do a thorough clinical intake. You need to do testings, enough of them to be able to validate your diagnosis, so that we can be able to know how to go about in treating our clients. So let's begin with hypochondriasis. And basically, this is a physical complaint without a clear medical cause, and causes the client to be very, very anxious, and makes the client unable to function normally, makes the client be able to settle properly, because this pain is real in their mind. It's very, very real. And even after the medical reassurance that this pain is not there, the client is not convinced. And that's why, after going through various probably health facility, or through various doctors, the eventuality that the client will be referred to you as say a counseling psychologist or a practitioner in this field, or a mental health practitioner, is very, very high, because then the doctors are unable to see anything that can actually be able to pin them down on a very physical problem. And as you do your diagnosis, it's important that you also you want to check if there's an anxiety or any mood disorder. Remember, some of the types of mood disorders is depression, because this is a person who has been having a persistent physical complaint, and the doctors are saying no, it's not there, it doesn't appear, it's not there, and therefore this could actually fall the person into a depressive mood disorder. Or you want to also look at other disorders such as bipolar, amongst others. So basically rule out any other comorbid, just for you to check. So we bring this a little bit earlier so that when you're doing your clinical intake, you also want to see whether there is any linkage between this and the mood disorder or anxiety disorder. So make sure you assess for these two, very, very important, because it automatically comes with an anxiety. But then that does not necessarily mean that every client presenting with a hypochondriasis will come with a mood or anxiety disorder. But we are saying that it's important that you try to ascertain and rule out just in case. So some of the characteristics of the features that come with this disorder is anxiety, of course, panic, preoccupation with physical symptoms, and even with the reassurance, the client seemed not to be reassured that they didn't have a physical problem. And one of the key or the core diagnostic feature for this disorder is basically the conviction that the client seem to say that, or seem to have, that they have a disease. So it's a very, very important feature to take note of, that there is conviction of a disease. So very, 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 very important to take note of that. Remember that hypochondriasis is different from phobia. It's different from just normal fear or anxiety. It is where someone is preoccupied with a physical complaint and there is no explanation, medical explanation about this physical complaint. Of course, fear is part of it, in the sense that it brings anxiety, brings fear, and the person's cognitions, the way they think, the way they perceive with their senses, and their emotions usually are distorted because it's this preoccupation of a physical complaint. Now, for every pain that comes, it is a threatening pain, because already there's a pain that is already seemed to be there. So every other pain that comes, even a minor pain, the client will perceive it as a very threatening pain. And because of the anxiety that has been created, it makes the symptoms even terrible and more worse for the client, and that's why they seek help. So it's important just to take that. My emphasis is in history taking, or the clinical intake. It's very important that once you start perceiving you're dealing with a client with a somatoform disorder, always take a very, very thorough clinical intake, so that you have enough history, you have enough information for your basis for your testing, so that you can make your conclusion in terms of diagnosis. So one of the main treatment that has seemed to be working is CBT, and as I told you, I will be taking you through CBT in terms of the components and in terms of the core features, so that we understand how to be using CBT when we need to use it, and if we are comfortable using it, then I will be bringing this to you. But CBT seems to be one of the most recommendable treatment strategies, in the sense that you want to challenge, or you want to challenge the negative thoughts that the client is presenting with, which affect the way they are behaving, and eventually it is going to affect the way they feel. But we will talk more about CBT in another class, because I need to give you more on how to use CBT in terms of its components, some of its features, and how to use it when you're using it as a treatment plan for various conditions, not just this, but various conditions. The next is a somatization disorder, and basically a person or a client presents with an extended history of physical complaints. Usually the onset is before age 30, and this causes an impairment in social or occupational functioning. You know, the hypochondriasis is more of a disease. So I have this disease, maybe I have a skin disease, but this is more of a physical complaint. It could be just a pain that has been there forever. Not necessarily the person says that it's a disease, but it's just a pain that has been there forever. So when you're looking at symptoms, you want to look at least they will present with types at 4 different pains, maybe pain here, pain there, etc. 3 of the symptoms presented are usually to do with the gastrointestinal. 1 sexual symptom is possible and 1 neurological symptom is very possible. So look at these symptoms and see whether they are presented with the client. But these symptoms causes a lot of social or occupational functioning of the client. Now, when you're looking at when you're dealing with a client with a somatization disorder, the focus of the client is more on the symptoms instead of what they mean. In the hypochondriasis, it's more of what they mean. I could have this condition. But in somatization, it's more of the symptoms as opposed to what they mean. And all they want to do is, I want you to help me deal with these symptoms. And these symptoms become a part of their identity, part of what they go through every other day. And these symptoms are supposed to be chronic for you to say that this is actually a somatization disorder. People say a lot of single women and people coming from low social economic status could actually vulnerable to this kind of disorder, but that's not necessarily that. It just says it's more in this kind of a population, but doesn't mean that other condition or people with different status don't present with this condition. It's just it's common among these people in this status. When doing a history for males, you'll see that, of course, we need to also say that there's a big linkage between this condition and antisocial disorder. Antisocial personal disorder, and we'll be looking at personal disorders very soon. But there's a big linkage between this. So, what are we trying to also say? Always very important to look for comorbids if they are available in any condition. In my own experience, I know clients can come with 1 condition, but after probably I may have missed any information clinical, but when I do the test, the good thing about most of our psychometric tools, they assess for other conditions. So even if you missed on the clinical intake, when you do test, look at the ones that are presenting with severe conditions from other conditions, and this is when you want to see if there's any linkage between that disease or that disorder with another one that is already existing. For males with somatization disorder, they're likely to be more aggressive. Females are likely to be more dependent on others for things, assurances on how they look like amongst etc. Again, they believe that this is a condition that can only be treated by a medic. So you really have to work hard on convincing the client that this is a psychological problem as opposed to a physical problem. And that's why they rely so much. They rely so much on the physician, because they believe that this is the person who can actually treat them well. Again, no effective treatment, CBT can work, and most of the strategies most of the treatment strategies we've learned in therapy in class can actually still work for this condition. We have another one we call conversion disorder, and a conversion disorder. I don't know if some of us have seen happenings around young people who are in high school. All of a sudden, we saw, like for example in Kenya, we saw a school where the whole school, students were coughing, and then all of a sudden they were said to be fainting a lot, and they had to be taken through a lot of processes until it was said no, they don't have any form of a physical complaint. Initially it was said that they have a serious cough that requires treatment, but then later there was this fainting that was said to be so much, and after they went through a clinical intake and history taking and testing, they found that they had no specific physical complaint, but they said the conversion disorder. So usually it resembles a neurological disorder, and someone will faint out, and people will fail for this and interpret it differently in terms of what people seem to understand. As we saw, it can affect a whole population, even a whole class. One person begins and then the whole class picks up. And you'll see look at some of the symptoms. There's a slide that is missing, but basically you'll find that the class who will present with this conversion disorder and talk about having a problem in their chest, and that's why they're having this issue. So a lot of people have gone through training to understand this disorder. What they usually do is just have the person sleep down, have a small rest, and then wake up and is like nothing has happened. I don't want to mention the schools, but we've seen this happen here a lot of time, and we see a lot of mass conversions where the whole population in the school converses out of a problem that they seem to understand is probably culturally. It's within the school and therefore requires, sometimes they even want to, they would call for a religious touch. Maybe that will help, but it's a conversion disorder. Again, anxiety, especially like students when they want to sit for exams or they've not done their assignments and etc. They're likely to get themselves in this kind of a situation where they convert. And therefore, for that reason, it's important just to see how to help them. CBT still works again, but most of the strategies we've learned in psychology still also works. We have a pain disorder, and this is a pain that is real. They will talk about a certain pain that is really and persistent. And a client will say it is really, really nagging. It is really disturbing. It's really very, very painful. A specific pain. They will be very, very specific about that pain. So they will come up with this pain and say it is real, it's nagging, and they will go to every health facility that they know, or every doctor they know. They will call, they will want to know what is it really happening. But then there's no medical explanation of that pain. For body dysmorphic disorder, they think they have a given defect on the body. For example, my nose has a defect, or my face has a defect. In fact, they would even want to go for, plastic surgery. They have preoccupied defect. They can talk of even a finger that seems to have a defect, or they have a tooth. But necessarily, there's nothing. Even physical observation, you don't see anything. There's no defect. They're beautiful. They are good. But they can, because of this, they can engage in very suicidal behavior. See, if a teenager is complaining of having an ugly face, a defected face, what else would they want to think about? Or think about, let me just finish myself because I'm unworthy, I'm ugly, and etc. So this affects the way they think, the way they behave, the way they display their emotions. Some of them go into depressive situations. They can get even to a major depression, because this has to do with your body. And imagine if you think your body is defected in one way or the other. That can really be terrible. And for that, as you see, we indicated here, most of them will end up going for plastic surgery just because they want to correct this defect. And if not, you can see with CBT plus combination of treatments like antidepressants might really be important, because this person is really preoccupied in terms of how they look like, how they are, the defect they have, and how this is causing them. They don't want to even go to a mirror. They don't want, and even the assurance you're beautiful, you're handsome, you look good. This person is not convinced. Quite really severe condition as it is. So most important is just look at comorbids, look at other conditions pre-existing, try to combine as much as different types of strategies in terms of treatment so that you can help the clients go through these conditions. Let's look at dissociative disorder. Sorry for, I can see we seem to have had this slide having an issue, but basically we want to look at the second category, which is the dissociative disorders, and depersonalization, derealization, and dissociative amnesia, dissociative fatigue, among us other ones we're going to look at. But basically, we have 5 types of dissociative disorders, and We have what we call depersonalization and realization. We will look at them. We have dissociative amnesia. We will look at it. We have dissociative fake. We'll look at it. We look at dissociative trance, and of course, we're going to look at dissociative identity. So let's look at various types of these disorders. Let's begin with depersonalization. Depersonalization, and this is we looked at this time a little bit earlier, as you remember, in one of our beginning of classes, when looking at symptomology of mental disorders. We looked at this term, and depersonalization is simply when the person is detached from the self. You detach from yourself. The word person, depersonalization. So detached from yourself. It's a very chronic condition. The person is detached from themselves. They have little about themselves. Their short-term memory has a defect. Their spatial reasoning, the perception about the self. It's about the self. So they can't remember so much about themselves, even past events. Just like, for example, where they lived, who they are, etc. And this disorder has to do a lot of time with people who are traumatized. People who are traumatized a lot of time have this present with the personalization and even derealization. So we'll look at it as we move on some of the areas that seem to be of concern. But we'll talk before we look at dissociative amnesia, we'll talk about depersonalization, and we're just basically looking at a person who is detached from themselves. And as I said, a lot of times the background is usually trauma. And you forget, you have a little about yourself, not necessarily even forgetting, but you seem to have so less about yourself. Dissociative amnesia is basically unable to recall information about the person, and from the word amnesia, just about forgetfulness. And usually when a person has gone through a very stressful and traumatic event. Dissociative fake, on the other side, is the person travels away from home, but they can't recall, it's like they can't recall, they have been able to recall one's person and the identity of who they are. So even if they can move from here to a place like the downtown, and they have no idea what is it that they are about themselves and how they call themselves there. They even have no idea who probably their names are and etc. So basically, they forget. They have inability to recall their past and even who they are at the moment. Now, as we say, there's a lot of trauma related to dissociative disorders. So because of this trauma, if you treat trauma, the person might just normalize and go back to who they are themselves. So trauma is key in helping us treat these clients. Now, I know we'll have a lot of debate here, and people will be talking about this. But dissociative trance is basically when the person believes that they are possessed with spirits. Again, I don't want to emphasize here, but it's causing the person not to function well. The person cannot even be, in terms of social, in terms of cognitive, in terms of every aspect of this person, is not functioning well because they believe they are possessed by spirits. And they're going to various trance, and these are the possessions. There's always a cultural and a religious aspect attached to it. And in this kind of situation, I always remember, we've talked about the biopsychosocial cultural model of treatment of clients. It's you to see where this client fits and what works best for the client. Because you could, as a mental health practitioner, really want to help this client, but then the client is adamant about this kind of help, and therefore they find it very difficult. So it's you to fit, look at the model we've always said. Where does the client fit and which treatment strategy works well for them? If it's cultural, if it's religious, you know how to refer this client to this kind of practitioners who can help this client. So most of the time you see it's considered pathological within various client setups, and when the client is possessed by spirits, definitely from various culture there will be various approaches in terms of treating this client. But again, as I said, as a practitioner, it's you, or as an expert, it's you to assess in terms of biopsychosocial cultural model, see where the client fits and see how best that you can help the client in terms of recovery. DID, dissociative identity disorder. Some people have said this is called, and or probably we could say in the past, it's well known for multiple personality disorder, and where client has altered personalities of different fragments of personalities existing within one body. Today, this time they could play their mom. The next minute they are becoming their parents. The next time they are becoming a child. The next time they are becoming a teacher. So they play within a very, in the same person, the person alters these personalities. And these personalities are usually fragmented or dissociated, as you can't be a child and a mother at the same time. So they're really dissociated. And clients they keep switching from one personality to another. And this includes even physical changes, even dressing, in terms of the way they look, in terms of the way they portray their personalities of these different peoples. Again, as I say, quite really tough treating some of these conditions. And these clients really try to hide these symptoms. I wish there were people here to share some of these experiences. Sometimes we've come across these experiences, it would have been nice. But again, these individuals try to attempt to hide them. A lot of these people or individuals or clients will obviously have auditory or present with auditory hallucinations, and they come with, because these hallucinations it's because of a given person that they are altered into this time, and therefore they will speak to themselves. They will be able to, they're communicating with this personality. So basically, auditory hallucinations are common. DID is also said to be common among people who have been neglected or sexually abused or having a childhood abuse of given conditions, people with post-traumatic stress disorders. And it's important to be very thorough in your clinical intake. It's important to also be very thorough in your history taking, so that you want to be sure that there is no, you rule out or you validate if there is an abuse or a neglect or a PTSD of a given situation. Try much. And they say a lot of people with, or clients with DID, there's a child abuse, 97% child abuse. So try establish that. And then now, combination of your treatment strategies, help the client. A lot of people have said that also dissociation is used as a defense mechanism against severe trauma. There's always, as I said, there's PTSD or trauma, or, you know, child abuse brings trauma, it brings PTSD. So basically, as I said, yes, can be a defense mechanism, but we are saying these are real disorders. We can see it as a diagnostic criteria for you to be able to ascertain that the person went through a given childhood or PTSD or a traumatic event. The client can portray with some real memories. Some of them are false. Again, it's important that you look through these conditions. They will portray with different personalities in terms of their behavior, in terms of their voice, posture. As I said, they portray a real person of that personality when they switch to that. If it's female, if it's male, if it is a parent, if it's a child, they portray almost a real personality of that person. Most people with dissociative DID is females, maybe because, again, childhood, like rape and amongst many others, most will occur among women. So that's probably why a lot of women would portray with this kind of a disorder. It's usually severe, it's chronic, and again, the emphasis is a sexual abuse of any past. It's important that you look at it. And you see, we are saying this person can alter as much as different alterations of different people, personalities, behavior, posture, etc. So the person can actually, you know, alter in many ways, even as many as 100 personalities or self-identities. So they use, a class would use, as you say that this could also be a form of defense mechanism. It's because this is the best way to survive, you know, and they use this for a lot of time to survive. But as you're saying, that this survival is short-lived because it affects the person's way of thinking, the way they perceive. It affects the person's functioning in a normal setup, as environmental setup. So basically, it's not something that you're saying it's going to be reliable at any point of time. So check out also for PTSD, validate or rule out, just in case it is there. Some of the treatment, we won't go to every, but just want to say that you want to use reintegration identities to help the client see how to reintegrate these identities, the different forms of the identity the client is portraying. Try to neutralize cues that bring out these identities, and then you treat trauma. If trauma is there, treat trauma, because if you do trauma, if you treat trauma, you're likely to treat this. And then of course, meditation, hypnosis, mindfulness, therapies, they do work for this kind of treatment. You want to combine trauma-related treatment strategies as well as some of the ones that we are mentioning here. It doesn't mean that this is really the perfect model of treatment, because we're saying that trauma is also involved. So you might just want to combine various treatments for trauma with these, some of these treatment options, and I'm sure the client will definitely be helped in one way or the other. So basically, this is what you've talked about, the two main disorders, somatoform disorders and dissociative disorders. In case you have any question, you're free to call and ask me. I know we are having so much to do, but I want to bring this lecture to the end, unless you have any question. Let me hear. You can write me, you can call me, you can ask me. So, thank you.